Hello, welcome to another session of Zooming Through ID. I am Dr. Gopal, an infectious disease specialist, trained at Duke University, been practicing in South Florida for a little over 20 years. I am the medical director here at Broward Health North. I do teach residents and fellows, and I'm the APD for Infectious Disease Fellowship program. I do chair the antibiotic stewardship. So today the presenter is going to be Eduardo, and Eduardo was rounding with me, and we were talking about Mycobacterium, and I was talking about Mycobacterium chimera, and he was fascinated by that. The reason being, he wants to become a cardiologist, and this chimera was associated with heater cooler system and infections in the cardiac infections, device infections. So he wanted to do some research about that, and he's going to present that topic today. So it's going to be awesome. I love that particular strain and how the whole thing has evolved. And Mycobacterium chimera is going to be the topic today. So I will introduce you all to Eduardo. So you can go ahead and start and introduce yourself and get the
Of
presentation.
course. Thank you, Dr. Gopal. Hi, I'm Eduardo Palmero. I'm one of the interns at Broward Health North with the internal medicine program. My passion, as Dr. Gopal was saying, is cardiology. And I really love the infectious disease rotation because we got to see a lot of infectious endocarditis, a lot of other infections. And that's why I'm presenting today, the cardiovascular device infection and the emerging role of Mycobacterium chimera. So I'll go ahead and share my screen right now. Uh, so- can you see it?
Yes, perfect. Yeah.
Okay, excellent. So, okay, welcome and thank you for joining today's talk. Today we will be exploring the landscape of cardiovascular device infections, a topic that is both high yield for both board exams and clinically impactful in real world practice. So in particular, I'll be highlighting the Mycobacterium chimera, as Dr. Gopal was saying earlier, a rare but very important pathogen that emerged in the context of cardiac surgery via heater cooler units. And our goal is to enhance the understanding, sharpen diagnostic reasoning, and reinforcing evidence-based management strategies. So I'll go ahead and put the next slide. So perfect. Let's start by outlining the devices we're focusing on today. Cardiac implantable electronic devices, ICDs and CRTs, they are becoming increasingly common as our population ages and the indication for implantation broaden. So prosthetic heart valves, both mechanical and bioprosthetic, are another major category of these cardiovascular devices. This can be infected with typical and atypical organisms. Also, the ventricular assist devices, such as the LVAS, are used in advanced heart failure and are associated with high infection risk due to driveline exposure. And finally, as I was saying earlier, we have the heater cooler units used mainly in cardiopulmonary bypass cardiac surgeries, which have been implicated in the outbreaks of Mycobacterium chimera. And basically, understanding the range of devices helps frame the diagnostic and therapeutic strategies we will discuss ahead. So let's start with the clinical relevance. Device-related infections are becoming increasingly important due to the rising use of implanted cardiac hardwares. As I was saying earlier, CEIDs have a 1.5 to 2% infection rate. And although that may seem low, given the number of implants that we have on our population is significant, is a significant burden. So valves and VAD have even higher risks especially in immunocompromised or comorbid patients. Also, infections can be localized or progress to systemic complications such as sepsis, embolic strokes, or even multi-organ failure. Mortality from prosthetic valve endocarditis, for instance, can exceed 30%, so that's a really high number. And recognizing these infections early is key to improving outcomes and preventing catastrophic complications too. Let's go ahead with the pathophysiology of the device-related infections. So mainly, the pathophysiology resolves around the biofilm formation. Once the device surface is colonized, bacteria produce a protective extracellular matrix, and this biofilm prevents immune cells from clearing the infection and renders antibiotics much less effective. Carrying implantable external devices, infections can originate at the time of the surgery or via bloodstream infections. And driveline infections in VADs are especially common due to the external exit points. Also, the prosthetic valves being foreign materials are also highly susceptible for bacterial colonization during a surgery, even from a transient bacteremia, such as a dental workup or even line infections. And Staphylococcus aureus, especially MRSA, and also coagulase negative staph like Staphylococcus epidermidis are most common in CIEDs and valve infections. Let's go ahead with the clinical presentation. So patients with device infections can present in multiple ways. For the cardiac devices, local signs at the generator site, such as redness, warmth, tenderness, or even purulent drainage, are classic. But systemic symptoms such as fever or chills may point to bacteremia or even deeper involvement. BADs patients may also present with localized driveline infections, but also can present as septic patients. Also, if a device is infected and no longer functioning properly, patient may experience some signs or symptoms of bradycardia or even inappropriate ICD shocks. And also in valve infections, we may find signs of endocarditis like a new murmur or even peripheral signs, including the Janewell lesion or even the Osler nodes. Now, for the diagnosis of the typical device infections, well, diagnosis obviously starts with blood cultures, at least 3 sets prior to initiating the antibiotics to maximize the yield. If the infection is if the device is removed, sorry, we have to send the leads or the driveline for culture too. Also, the echocardiography is key in the diagnosis of these infections. TTE, the transthoracic echocardiogram for initial evaluation, and the TEE, the transesophageal echocardiogram for better resolution. TEE is superior for detecting vegetations on lead or on prosthetic valves. And for prosthetic material, we can also use a imaging tool called PET-CT and TACT WBC scans. These studies can localize inflammation that echocardiography may miss. We have obviously to always correlate clinical symptoms with microbiologic and imaging findings for a definitive diagnosis. Well, this flow chart basically resumes the diagnosis of typical device infections, outlines step by step the diagnostic approach for the cardiovascular implantable electronic device infections. And these infections can be localized to the POC or in systemic spread, such as endocarditis. So the initial step, basically for all the patients with device infection, we have to start with blood cultures and assess for systemic signs. So if cultures are positive, or if the patient was on prior antibiotics, we proceed with transesophageal echocardiography. as we see on the left side of the flow chart, to evaluate for vegetations. If we find positive TEE findings, if we find valve vegetation, we manage as infective endocarditis using the AHA guidelines for infective endocarditis. On the other side, if we have lead vegetations, we determine if the infection is complicated or uncomplicated. Complicated meaning that the patient has osteomyelitis, septic thrombosis, etc., which guides the antibiotic duration. We see down there 4 to 6 weeks of antibiotics. On the other side, if the TEE is negative, if the patient has Staph aureus bacteremia, we treat with 2 to 4 weeks of IV antibiotics and then repeat the TEE if treated for 2 weeks. If the infection is non-Staph aureus, we treat the patient with 2 weeks of antibiotics, and that may be sufficient. On the right side of the flow chart, if we have negative blood cultures, we evaluate for pocket infections. If the patient has a pocket infection, we treat the patient with 10 to 14 days of IV antibiotics. And if we have a lead or generator erosion, we only treat the patient for 7 to 10 days of IV antibiotic. So basically, the key teaching point of this flowchart is that early imaging and identifying whether the infection is localized or systemic, since this determines both the duration and the aggressiveness of the antibiotic therapy. Now we have another algorithm that focuses on the safe re-implantation of a new cardiovascular implantable electronic device after an infection-related removal. Timing is critical to avoid the recurrence of the infections on these patients. So the first thing we have to do is to remove the infected device, obviously, to repeat blood cultures. If there's valve vegetations, the re-implant, we have to re-implant the device after 14 days from the first negative blood culture. If we have lead-only vegetation, we have to re-implant after 72 hours of negative cultures. Then the second scenario in the middle, we have positive blood culture plus negative TEE. We have to repeat blood cultures after the device removal, and then re-implant after 72 hours of negative cultures. And the third scenario on the right side, it says local pocket or lead erosion and no bacteremia. We have to debride the generator pocket and ensure 72 hours of negative cultures, and then re-implant the new device immediately after adequate local control. So treatment of the device infections require complete removal of infected hardware, as I said before. Biofilms prevent antibiotic-only approaching from working, so we have to remove the device. Empiric antibiotics should cover MRSA and gram-negatives. Some options include vancomycin with ceftriaxone or even daptomycin with ceftaroline. And once culture return, we have to narrow the therapy as we talked before on the flow charts. So now I'm going to talk about the emerging threat about the Mycobacterium Chimaera. This is an emerging and insidious pathogen, as I was saying before, Mycobacterium Chimaera. And this organism is not part of the typical CIED flora. So Mycobacterium Chimaera is a slow-growing non-tuberculous mycobacterium, part of the Mycobacterium avium complex. It's environmental and typically harmless unless it enters the body through an invasive medical procedure. So outbreaks were tracked back to heater-cooler units using cardiac surgery. Also, contaminated water in these machines became aerosolized during surgery, allowing the bacteria to reach the open chest cavities. And a unique feature is the prolonged incubation period. It is often between 12 and 12 to 36 months. So this makes the diagnosis of Mycobacterium Chimaera delayed and very difficult. And recognizing this route of transmission was key to identify and manage these infections. So I'm going to talk about a little bit about the epidemiology and transmission of Mycobacterium Chimaera. Mycobacterium Chimaera outbreaks were first detected in Europe and later globally. The first outbreak of Mycobacterium Chimaera infections linked to cardiac surgery occurred in Switzerland between 2011 and 2014. Over time, more than 100 patients were affected worldwide, with many cases reported across Europe, North America, and even Australia. Some investigation traced the source to the Stoker's 3T heater units, which were contaminated during manufacturing at a single production facility. And during open heart surgeries, such as CABG, these devices aerosolize contaminated water, introducing the Mycobacterium chimaera into the sterile surgical field and exposing the patient to these bacteria. And this unique transmission pathway through equipment contamination has raised global awareness and prompted a public health action too. So now I'm going to talk a little bit about the clinical features of Mycobacterium chimaera. Patients with Mycobacterium chimaera infections often present with non-specific systemic symptoms such as fatigue, low-grade fever, night sweats, weight loss, and even anemia. Symptoms usually appear months to even years after cardiac surgery, leading to delays in diagnosis, as I was saying before. And multi-system involvement is really common. It can affect the liver, leading to hepatitis, can affect the kidneys, leading to nephritis, and it can affect the eyes, leading to choroiditis. Because of this wide range of symptoms, the condition is often misdiagnosed as sarcoidosis, tuberculosis, or even lymphoma, which can delay the proper treatment for these bacteria. Therefore, we as clinicians must maintain a high index of suspicion, especially in patients with a history of cardiac surgery, CABG, and persistent systemic symptoms. I'm going to talk a little bit about the diagnosis of Mycobacterium chimaera. So diagnosing Mycobacterium chimaera infection is often delayed, as I was saying before, due to its non-specific symptoms and slow-growing nature. So we have to begin with a thorough surgical history, especially asking about cardiac surgeries with bypass. These are high-risk exposure. AFB cultures from blood or tissues are the mainstay, but may take 2 to 6 weeks to grow, so they are not immediately informative for us. Also, tissue biopsy often reveals necrotizing granulomas, which can point toward the mycobacterial infection. And there's some specific tests, such as the 16S RNA PCR or even whole genome sequencing that helps expedite the diagnosis and link cases to known outbreaks. Also, PET-CT is a valuable imaging tool to identify prosthetic valve or graft infections, especially when microbiologic testings are still pending. So basically, this slide showcases the multimodal approach to diagnosing the Mycobacterium chimaera prosthetic valve endocarditis. So we see on panel A to D, that is a transesophageal echocardiography imaging with findings like paravalvular abscesses, some pseudoaneurysms, and some echo dense structures, which raise suspicion for a prosthetic valve infection. Then panels E and F are histopathology that shows the granulomatous inflammation that is seen in lung and cardiac tissue, typical of the mycobacterial infections. Then the panel G shows the biofilm formation of an explanted prosthetic valve ring. highlighting the persistent infection despite the prolonged antibiotics. And then the last image is an ocular fundus image illustrating the choroiditis, which can be occluded to disseminated Mycobacteria Chimaera infection. And altogether, these findings emphasize that diagnosing often relies on a combination of imaging, pathology, microbiology, and also clinical suspicion, obviously. So we're going to continue with the treatment of Mycobacteria Chimaera. So treating these bacteria is both prolonged and very complex. So the standard regimen included macrolide antibiotic, either clarithromycin or azithromycin, combined with rifampin and ethambutol. In more disseminated or severe cases, we add amikacin and aminoglucoside for enhanced initial bactericidal activity. Therapy duration typically exceed 12 to 18 months, so it's a very prolonged therapy, and sometimes longer depending on the clinical and microbiology response of the patient. Drug levels also obviously should be monitored, especially for agents like amikacin, to avoid toxicity. And this approach is obviously aligned with treatment strategy for non-tuberculous mycobacterial infections in immunocompromised or post-surgical patients.
Yeah. Eduardo, let me add a little bit more to the treatment area. So the
I
typical,
added some.
yeah, you added some more
Mhm.
therapeutics. Okay, go ahead. Yeah.
Yeah, from the article you sent me.
Oh, wonderful,
So
wonderful. Yeah. Okay, great. Oh, there.
yeah,
Oh,
so
beautiful. Okay.
yeah, Dr. Gopal sent me an article, yeah, about all the treatments. So I'm gonna talk about this one. Let's take a closer look to the pharmacologic treatment options for Mycobacterium chimera. Which, as you recall, as I was saying earlier, often requires a prolonged and complex multi-drug regimen. So this table basically summarizes recommended therapies, dosing strategies, major adverse effects, and practical clinical considerations for each drug. So we're going to start with the macrolides, azithromycin and clarithromycin. These are the cornerstone of therapy for mycobacterium therapy and should always be included unless contraindicated. Both can cause GI upset, QT prolongation, and even ototoxicity. And clarithromycin is most likely to cause eosinophilic pneumonia. So a very important thing to think about when prescribing this medication is that if the patient has renal impairment, particularly creatinine clearance less than 30, clarithromycin dosing should be halved. Then we continue with the rifamycins. We continue with rifampin and rifabutin. Both drugs induce liver enzymes and may discolor body fluids. Rifampin, in particular, has interaction with some calcineurin inhibitors, such as mycophenolate, and this is very important in post-transplant patients too. Then we continue with aminoglycoside with amikacin. This is reserved for severe or disseminated infection. The main concern with this medication is nephrotoxicity and ototoxicity. So baseline and periodic evaluations of this system are recommended. And therapy typically lasts 6 to 12 weeks to enhance sterilization of the blood and tissue cultures. Next medication is ethambutol, included as a third line oral agent, known for its risk of obviously optic neuritis. So we have to do ocular assessment periodically. Next medication is clofazimine. This medication was originally used for leprosy, but now being repurposed for the treatment of Mycobacterium chimera too. It has some side effects such as skin discoloration and DRSS, and also QT prolongation. Then we have the bedaquiline. This is not a first-line agent, but considered for salvage therapy in patients that are allergic to any of the previous medication. Then we have linezolid. This is a highly potent agent, but very toxic too. Can cause hematologic suppression and lactic acidosis. This is not a first line agent, but as I was saying before, we can use this in some patients. And the next one and last one is moxifloxacin. This is used as a secondary or salvage agent too, and carry the box warning for tendinopathy, QT prolongation, and even central nervous system effects. We have to avoid this medication also in patients with myasthenia gravis or those at risk with neurotoxicity. So in practice, we typically start with a backbone of clarithromycin, rifampin, and ethambutol, and then escalate the antibiotic therapy based on the severity and the culture data. Monitoring and those adjustments are essential to reduce cumulative toxicity during prolonged therapy. Do you want to add something else about the therapy, Dr. Gopal?
No, I think this is excellent. This is exactly what I wanted. This is a very nice article and thorough table. The challenges that we have with this mycobacterial infections is the length of therapy is too, it's and the side effects that we go through. And if we have issues with one medication, we have limited options because of the side effects and the duration. So this is perfect. Yeah. Okay, you can.
That's right. Yeah, so I'm going to go ahead and complication of the infection of Mycobacterium chimera. So if untreated or misdiagnosed, Mycobacterium chimera can cause disseminated infection involving the liver, eyes, bone marrow, and even kidneys, as I was saying before. Mortality in systemic infection exceeds 40 to 50%. So this is really high. Eye involvement is also specific. We have to look for vision changes and choroiditis. Device-related endocarditis may result in prosthetic dysfunction and severe heart failure, also leading to cardiogenic shock in some cases. So early recognition and aggressive management reduce these risks. So prevention is the best defense for patients when talking about Mycobacterium chimera. So heater cooler units must be regularly decontaminated and tested for contamination. We have to ensure that the unit exhaust does not circulate into the sterile field. We have to use only sterile or ultrafiltrated water. And the CDC and the World Health Organization provide protocols on ACU handling and replacement timing. Post-market surveillance and manufacturer accountability are key moving forward with the prevention strategies. So basically, this is a table that outlines standardized recommendations for identifying possible cases of Mycobacterium chimera infections after cardiac surgeries. I'm going to go section by section. The first one is the exposure criteria. So to even be considered a risk, the patient must have undergone a cardiopulmonary bypass surgery before the onset of symptoms. So this includes valve replacements, graft surgeries, or any open heart procedures, where heater cooler units might have been used. The second point is the clinical criteria. The clinical spectrum is broad and often non-specific. It includes classic surgical site infections like prosthetic valve endocarditis, graft infections, sternotomy wound infections, or even mediastinitis, but also systemic manifestation that may not initially raise suspicion for Mycobacterium chimera, such as fever of unknown origin or even disseminated syndrome with symbolic immunologic signs, such as hepatosplenomegaly, arthritis, osteomyelitis, or even visual symptoms, such as choroiditis. So we have to keep in mind that these symptoms may appear 12 to 36 months post-op, which is why clinical suspicion is often low with this bacteria. The third point is in microbiology criteria. So key diagnostic microbiology findings include positive Mycobacterium chimera culture from heparin blood samples, also cultural PCR positivity from prosthetic adjacent cardiac tissue. And these are slow-growing organisms and may require, as I was saying before, from 6 to 8 weeks for culture to grow. So molecular diagnostics are vital for this condition. The fourth point is the histopathology criteria. So pathologists may find non-casserin granuloma and foamy or swollen macrophages, and the presence or absence of fast bacilli supports the diagnosis, particularly found near the prosthetic material. And the last point is the additional supporting criteria that include negative conventional blood cultures, also serologic testing to other pathogens that may be disseminated mycobacterial disease, such as Bartonella, Coxiella, Brucella, and even Trophorema whipple. So the main takeaway from this table is to think beyond the stuff in patients presenting with months after cardiac surgery with systemic or inflammatory symptoms. And adhering to structures diagnostic criteria helps us guide the testing, reduce missed cases of Mycobacterium chimera, and to improve the infection control efforts. So that's it for presentation of Mycobacterium chimera. I'm going to go ahead with a case. So basically, this case involves a 70-year-old male who underwent a aortic valve replacement with a bioprosthesis. So he presents nearly 18 months later with classic systemic signs of fatigue, weight loss, night sweats, and anemia. His symptoms were initially attributed to anemia of chronic disease. So a PET CT was ordered due to persistent elevation of inflammatory markers. Imaging showed increased FDG uptake at the prosthetic valve, suggestive of inflammatory or infectious pathology. And despite multiple blood cultures, all were negative, including the fungal and routine AFB stains. So differentials at that time included indolent infective endocarditis, malignancy, lymphoma, and granulomatous diseases like sarcoidosis. Then a biopsy of the PET avid region was obtained and showed necrotizing granulomatous inflammation at that time. Blood culture held for an extended incubation, flagged positive after 38 days, and identified Mycobacterium chimera by molecular testing. So the patient was started on a combination therapy with clarithromycin, ethambutol, and rifampin, along with IV amikacin for intensive early treatment. And despite partial clinical improvement, imaging continued to show prosthetic valve involvement. So he underwent successful surgical explantation and valve replacement. Cultures from the removed valve confirmed the Mycobacterium chimera infection. And after that, he completed 18 months of therapy with close ID follow-up at 12 months. PET-CT was negative and remained asymptomatic. Obviously, this case highlights the importance of long-term monitoring, surgical intervention, and the importance of suspicion of Mycobacterium chimera in systemic illness post-cardiac surgery. So let's go ahead with the questions. The first question, this is a 67-year-old man with a cardiac device and ICD presenting with signs of infection, low-grade fever, malaise, and redness at the poker sites. Cultures grew MRSA, and despite 5 days of IV vancomycin, the patient is still bacteremic. Importantly, TEE shows no vegetations. So the question here is, what is the best step in management of this patient? And the correct answer here is letter C. remove ICD and continue the IV antibiotics. So, according to the IDSA guidelines on cardiovascular implantable electronic devices, infections, persistent bacteremia in the setting of devices infection, even without vegetations on the TEE, mandates a complete removal of all the devices. So, question number 2. So here we have a 72-year-old female that presented with systemic symptoms that started 3 months ago, such as weight loss, fever, anemia, and night sweats. Importantly, she has a prosthetic mitral valve that was placed 2 years ago. With this PET CT that shows hypermetabolism around the valve and also has choroiditis on fundoscopic exam. The routine cultures were all negative, and the question here is what is the most appropriate next step in diagnosis? So the correct answer here is letter C, order AFB cultures and 16S RNA sequencing. So this is a classic presentation of disseminating Mycobacterium Chimaera infection associated with prior cardiothoracic surgery. So as we were saying before, Mycobacterium Chimaera infections are notoriously delayed, typically appearing 12 to 36 months after the valve or the graft implantation using the heater cooler units, and symptoms can mimic multiple conditions such as malignancy, lymphoma, tuberculosis, or even sarcoidosis. So question number 3, here we have a 64-year-old man confirmed with Mycobacterium Chimaera prosthetic valve endocarditis. He's received 6 weeks of combination therapy with rifampin, ethambutol, clarithromycin, and amikacin. However, amikacin had to be discontinued due to ototoxicity, which is a well-known adverse effect of these medications we were talking earlier. These 2 months of therapy, a follow-up PET CT scan still showed metabolic activity around the valve, suggesting persistent infection. So the question here is, what is the most appropriate next step in treatment? And the correct answer is letter C, proceed with a surgical valve replacement. So this case illustrates a key concept in the management of Mycobacterium Chimaera prosthetic infections. Antibiotics alone are frequently insufficient, as we were saying before, and studies and guideline-based experience show that eradication of Mycobacterium Chimaera, especially in prosthetic valve infections, requiring combined medical management with antibiotic therapy and surgical therapy with removal of the valve. And the last question, question number 4. So this case involves a 60-year-old male who underwent CABG surgery 15 months ago. He's currently asymptomatic, but a PET CT scan shows mild focal uptake near his aortic graft. He was exposed to a Stoker 3T heater cooler unit during the procedure. This is a key risk factor for Mycobacterium Chimaera infection. His blood culture is negative, but labs showed mild anemia and an elevated ESR, raising clinical suspicion for the infection. So the question here is, what is the most appropriate next step in evaluation of the patient? And the correct answer here would be letter C, perform biopsy and AFB cultures. So this clinical vignette is classic for the presentation of Mycobacterium Chimaera infection following exposure to the heater cooler unit, especially the Stoker 3T, which has been implicated in outbreaks globally previously, as I was saying before. So the key point is that symptoms may be subtle, or even delayed for 12 to 36 months after the procedure, and anemia and elevated inflammatory markers such as ESR and CRP are clearly systemic clues. Also, the PET-CT is a useful tool in this situation and in these patients. And focal uptake near the vascular graft or prosthetic valves raises concern for device-related granulomatous infection, even in the absence of bacteremia. So we also have to think about Mycobacterium Chimaera. So I think this was the last question. These are the references in Vancouver format. I think that will be.
Okay, great.
Thank you. Thank you very much.
So it was a wonderful presentation. It's a great topic. So I think this is very important to recognize the uh, condition. So that is one of the most important takeaway, like to be aware about this particular strain of Mycobacterium chimaera. And like Eduardo was mentioning, there is a lot of diagnostic challenges, and treatment is also challenging. So this is hope you all learned a lot, and this was a wonderful presentation, and I am pretty sure in this topic is very valuable for everyone, and for cardiology especially. The device related infections are a big problem in cardiology world, and so that is very important to recognize these type of infection. Okay, so great. Thank you all for joining.
Thank you. Thank you.